Hi everybody, this is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac User Group call for June 17th. We will get started here now. On the line with me, I have Melanie Bent from IQVIA and her team, and I have Leanne Jones, Jane Hahn, and a few other of my colleagues from STS. So we're going to get started here. Thanks for joining. First, I wanted to apologize because I had accidentally given our marketing team the wrong date, and it was posted as tomorrow. This call was posted as start being tomorrow on the website. And so I apologize, it was actually supposed to be for today. So we had updated the website and sent out the reminder this morning. So I apologize if this was last minute for you all. Try not to let that happen again. So we're going to get started here. I'm going to launch a poll. So we have about two weeks left to the start of version 4.20, which goes live on July 1st. And we have about 8 sections to continue to go through. Our next section to review is the Aorta section. And then after that, we a couple smaller sections, and then the post-operative section might be have a little bit more information we need to cover. So I wanted to just find out how you all wanted to handle this call today. So I'm ready to go over the aorta section and keep on going for the next 2 calls, just so we can see how much we can get through. So I think it's pretty. And then Melanie's going to give just a quick update on the harvest summary report before we get into the aorta section, because it looks like pretty much everybody wants to just continue on with the version 4.20 upgrade for this call and for the next call. First, I'll just give a few quick updates from STS, and then Melanie is going to give a couple updates from IQVIA, do a quick run through of the new harvest summary report, which became available last week, and then we'll get into the aorta section. So I'm going to end the poll now. It's pretty definite that what our plan is for today, and I'll share the results so everybody can see them. Put that down, and then hold on one second, please. Okay. Oopsie. Okay. So a couple updates from STS. We'll get through these pretty quickly. Again, AQO is going virtual. The Adult Cardiac Day is Thursday, October 1st. We have pretty much finalized pricing, but we're not able to share it just yet. As soon as we're able to share it, we will, and we'll pass all that information along, including the admission to submit abstracts. If you are planning to submit an abstract, I believe we've posted abstract information to get you started before even the abstract portal opens, just to get you started with what's expected in the abstracts, what's allowed, what's not allowed, and how that process is going to work. If we haven't posted it yet, Emily should be sending it out in the next couple of days here, just to give people a head start before we open that abstract portal. And then for version 4.20, our training manual was posted a couple weeks ago, and the worksheets are expected to be posted next week. I'm just reviewing them. Melinda completed them, and I'm just going to review them just to make sure formatting and things is good to go. So that's where we're at with those 2 things. The harvest report for for harvest 1 2020, which is data through December 30th of 2019, is not yet available. It will be available this summer, hopefully pretty soon here. We don't have a date yet. As soon as we do, we will communicate that out. The data is an analysis at DCRI, so as soon as DCRI finishes that analysis, they'll send the results back over to IQVIA, and then IQVIA will post it in the benchmarked dashboard, which is different from the uploader dashboard. So I'm going to now hand it over to Melanie and Jeanette for an update. Melanie?
Thanks, Carol. Hello, everyone. Not many updates, but we do have, of course, the new report that Carol had noted in regards to the harvest summary report that actually became available for users to access as of Monday. So you probably have already seen that if you've been in the application. So we'll get to a quick demo of that. But before I do that, I just wanted to do a recap of the items that were released over the weekend. The platform version was updated to version 1.29. In regards to that item, just know that again, we continue to do enhancements and upgrades. So that's a part of that process of making sure that the platform version is updated. So that's what happened this weekend. And then specific for adult cardiac, we had a couple of updates that were related to the dashboard report. 1853 was an item where a specific sub-report, which is called the other cardiac procedures report, when users would go into that section and select items, those values under the My Site, it was not generating the case list that were associated with those values. So we have corrected that. So you are now able to review the cases that are associated within that section. Another item that was updated was related to the graphs that are displaying at the very top of that dashboard. It was just a label update, so that was handled within this latest version. And then we did have to go in and update the valve devices and also ventricular assisted devices, or the VAD list. So that was done also. We do have another release that will be coming. Of course, that will be supporting our enablement for the direct data entry. So we have a lot of items related to that, which that release is targeted for the end of June. And then we do have updates that are related to the dashboard that we are also reviewing. So again, still in progress, but we will continue to share when those items are targeted and when you will see those updates in the platform. Okay, so that is the general update, and let's go ahead and go to the next slide, which basically is now my time to go ahead and share my screen. So let me go ahead and do that. Just give me a moment. And Carol, when you're able to see it, just give me confirmation. Let's see if this
Sure,
is
and
the
as you're
right.
pulling that up, I'm just going to report what I had said about, I'm going to restate what I had said about the 2019 outcomes harvest report that's Harvest 1 2020 with the data through December 30th, 2019. That report will be out this summer. We don't have an exact date yet, but as soon as we do, we will post it and we'll share information. The data is at DCRI and analysis now, and needs to get sent back to IQVIA for the benchmarked dashboard. That's where you'll find that data. So it's not out yet. Okay, I can see your screen, Melanie.
All right, thank you.
Mm-hmm.
And when that new report that Carol is referring to, when that is available, it will be accessible underneath the same menu where you've been going for the other reports. It will be available underneath the operational reports. So when that is available, of course, we will communicate that report availability. For this new one, you will locate the harvest summary report underneath the label of STS reports. And so this harvest summary report will navigate you to a parameter page similar to what you are used to seeing when you navigate to the missing variable report. And here you will just enter in a specific surgery date range that you would like to review, your current errors and warnings for your associated records. So let's go ahead and let's put in a time frame. I'm going to do 2018. I think I have some test data in for 2018, and I will do that through 2019. Okay, so I will do through December, apply the parameters, And let's go ahead and generate the report. And you will see that it will give you a similar look in regards to the DQR of what you were previously used to seeing, where you would have your pie chart, and then of course the listing of the records and associated errors and warnings. And so functionality is still the same. And again, the purpose of this report is to be able to give you a holistic view of all of the existing errors and warnings that are on your records. So if I were to left click and hold my mouse to go ahead and draw this shaded box over the pie chart, you'll notice that the cells for the related columns are highlighted. Again, similar functionality of what you would do in your DQR, you can do the same in this actual report. So I want to also point out the labels that you have. No validations, outstanding. So that means that there are no existing errors or warnings that are available on those records. Those have been satisfied. There is nothing that is triggering on those. So that's no validations, outstanding. And then you have outstanding errors, and then you have outstanding warnings. And really in this instance, the focus is on, of course, the higher severity, which is the errors, and then the warnings. You'll see that the information also populates at the very bottom. So everything is currently selected. And so you then will have all of those related errors and warnings at the bottom, and you can export those to Excel or to another spreadsheet program using the same functionality of just right-clicking on that section. Let's go ahead and let's bring up that menu. Let me see if I can get my mouse to work, because sometimes it doesn't want to work. And you will get your menu, and here you have the option to export. So you have export table without value formatting, and then of course Microsoft Excel export. And that will allow you to export all of the current errors and warnings. I do want to point out, and we are looking at a couple of enhancements on this report, so just want to note that we did get some general feedback, and a couple of feedback items that we are looking at is, of course, displaying the report range that was selected. But right now, the way you're able to review that report entry, the date range that you entered, you would have to select the arrow where it says expand. And once you do that, it changes to collapse, and you're able to then see that date range. We want to bring that here so you can easily see that. And another feedback point was, can you let us know the total number of cases that are available within this actual date range? And so we're looking at adding that information also. But in that regard, if you did want to see the total number of records that are associated with each one of the sections, so for example, I'm hovering over outstanding warnings, you'll see that there is a record count listed, which it shows 11 records are there. And then here you'll see there's 13. And then here you'll see there's 35. So you are able to see the record count association with each of the buckets that are listed here. So just wanted to also call that out. Okay, and another feedback point was in regards to no validations outstanding. It does show a number at this moment in time, but it actually does not give you an actual message at the bottom. It's a placeholder at the moment. And basically this placeholder is then generating all of the counts that are associated within this pie wedge. So we're looking at just maybe icon that maybe just validates that this is, there's no validations. Maybe we put a check, but again, it was another feedback item. But just know that even though you see a number here, it does not actually have an error or warning associated when you select it. Okay, so I'm going to stop there. That is the summary of this report. Hopefully some of you have already been able to go in and take a look, but that is now available for you to review. So I will go ahead and stop sharing, and Carol, I will turn it back over to you.
Melanie, can you go back one more second? I'm sorry.
Yeah, I can.
and show where to find this report? I just
I
want
sure can.
people understand what a harvest summary report is, what exactly that is. It's different than your benchmark dashboard. So
That is a great point.
yeah, underneath your operational tab, you're going to have these three selections. You're going to have the missing variable report, you're going to have the participant dashboard report, and then you're going to have your STS reports. When the benchmarked dashboards come back, that will be another type of operational report that you'll see. And I'm not sure if it's going to be underneath the participant dashboard report or if it's going to have its own drop-down menu. When that becomes available, you'll know. The harvest summary report is a report that is an inclusive report of the files you've submitted for analysis. And it's kind of like that big long report that you would get back from DCRI, just in an electronic format, and it's an inclusive report. So it will show errors and warnings. You can go in and look at your errors and then go back into if you want to update the errors, you could then go back into your vendor software, make the updates, and then re-upload the file. That those corrections or those changes will then populate in this harvest summary report as well. So it's more of an inclusive. You can select your date ranges, your date ranges.
Date ranges, yep.
Or what you want to look at and clean it up that way. So if you only want to look at a week at a time, you could do that. If you want to look at your whole year at a time, you can do that. So that's that. Do we know where we're going to post the benchmarked report when it comes back from DCRI?
It will be in this section. We have not decided if it's going to be either under the STS reports. It probably will be its own, just as how we had this participant dashboard. So we have not solidified the actual location, but it will be within this menu that we're currently looking at in operational reports.
And it will show you that it's an analyzed result. It will show that it's analyzed results, and it will show that it's the benchmarked results. So some way we'll identify it so you know that what you're looking at is the analyzed benchmark with your ODEs, your observed to expected ratios and things like that.
That's correct.
Okay, I just wanted to clarify because sometimes hearing it twice for me helps, so maybe it helps other people too. Okay.
Okay, I'll stop sharing and turn it back over to you.
Great, thank you. Okay, we're going to go over I'm going to share my other screen here. Let's see if we can do this. And we're going to start in the aorta section. Melanie, if you want to answer any of the questions in the Q&A and type them in, feel free. I just want to make sure we spend enough time going over the aorta section.
Okay.
People can see, as long as they're not sent privately, people can see the questions and answers that are being typed there. Okay, so we're going to get into this is the aorta section. It's going to be under M2. The first thing that I wanted to show is how do we get to the aorta section. This is for version 4.20 upgrade. Right now I'm in the operative section. I'm going to show you the parents to open up the aorta section. It's different than what it had been in 4.2 or 2.9. So let me get here. So these are your operative types here. So the first question is coronary artery bypass and aorta procedure performed. Okay, so that signifies to me that an aorta procedure performed, and this is saying for any of these three yeses, section M2 is going to open up. The next question, of course, did the surgeon provide input? And we've talked about those, and what you need to code that as yes is that you feel comfortable with the information you received either through consultation, dictations, surgical reports, or post-operative reports from the surgeons or the surgeon providers, that you felt comfortable. It could even be verbal communication. You felt comfortable that you were answering the questions with accurately and that you weren't making guesses. Again, we don't want guesses. We would rather you leave the field blank or missing or unavailable instead of guessing at data if you're not able to verify it with the surgeon. And then the next question is valve. So was a valve procedure performed? Now for procedures where you're going to have an aortic valve and an aorta procedure, you would, of course, you were going to select yes to the aortic procedure, and then the valve section you would select yes. Okay, and then was an aortic valve procedure performed is here. Now, if it was an aortic valve procedure performed, you would select yes in conjunction with this aorta yeses. And then it's going to say, was this next question, it seems you're going to say, well, that seems really redundant. But actually what happens, this question here, this wasn't a procedure performed on the aorta, no, is actually the parent to the aortic valve section. When you select wasn't it a procedure performed on the aorta, yes, the aortic valve section is not going to open. The only section that will open is this one of these yeses up here that opens M2. Okay, so I've selected yes to one of these, and I selected either no or no. I'm sorry, or I selected or did not select yes down here. So section M2 is going to open. Does that make sense? So there wasn't a procedure performed on the aorta. Yes. The yes does not have any impact on the aortic valve field. It will not open. The only thing that would open would be this section M2. So these have to, there's going to be a consistency check in place, is that if you selected was an aortic procedure performed yes, and you selected no up here, that's going to be an inconsistency in your vendor software, and you won't be able to go any further. So there has to be consistent documentation between this aorta proc 2123 and this AV aorta proc perf 2132. These both have to be yeses for M2 to open. If it's if this is yes and this is no, that's an inconsistency. If this is no and this is yes, that's an inconsistency. You won't be able to go any further. So I've answered it consistently. I said yes here and I said yes here. M2 is going to open. All right, so I get down into the M2 section. Which is here. Again, the form on the left with the orange, dark orange here is version 2.9 form with the changes noted. The form on the right with the purple is version 4.20 with only the new additions added in, highlighted in blue. So we start off with family disease of the aorta, genetic history. We added in aortic valve morphology. This is to capture those bicuspid valves or bicuspid valves here. And then we didn't make much changes to this section. We just added in what the root or what the ascending, we added in the zones for those to just be a little bit more clear. And then we did a little bit of rearranging here with the endo leaks and infections and traumas related to the current procedure. So current procedure with endo leak, and then if yes, you pick the type of endo leak. We had a little bit of this previously we were capturing endo leak on any case and any procedure not related to current could not be related to the current procedure. So what we really want to know is the current procedure, is this related to an endo leak or is it related to an infection of the aorta? Was that infection? The types are listed here, and then the current procedure was with trauma, and then where was that trauma located? The definitions for this field 4675 is unchanged. It is in the training manual. Make sure you go back through the training manual and review the definitions as you're abstracting. And then we get down, so trauma, you can select the section, and then the presenting symptoms. We added in a couple here, injury related to surgical complication. So this could be, probably this would be your unplanned due to surgical complication where you selected the aorta section or aorta yes. You would then check here, and that can be, say they were doing a cabbage and something happened to the aorta, that's where you would select this field. And then neuro deficit, other or unknown. If there's a neuro deficit, we just kind of pulled this out a little bit further. So you didn't have all these choices to go through because the ones that we listed here under 4710 are the most, were the most chosen choices for 2.9. So instead of cramming up this field with additional, we pulled these out into their own shortening, own field here under narrow deficit and the types. And for hoarseness, it's related to acute vocal cord dysfunction. And that was to provide some clarity that it is acute, meaning that it's nothing that the patient had chronically. Then we get into primary indication. We have aneurysm, dissection, and other. For if you've chosen aneurysm, these are the fields that you fill out for that: the etiology, type, rupture, and location of maximum diameter. Under etiology, we just added in here, because we did get some questions about ulcerative plaque. We added that penetrating ulcer, ulcerative plaque are to be captured under the same. That was from FAQs that were submitted in. And then we have the connecting tissue syndromic disorder, goes here. Again, the aortic valve morphology, and then chronic dissection. Those were things that we were not capturing in 2.9. We had gotten quite a bit of FAQs regarding these when we went live, so we've added them in here. And then in the dissection, we clarified, if it was a dissection, we capture timing, the date of onset, the primary tear location, the proximal dissection extent known, and if so, where was that? Distal dissection extent known, how far down did it go? The Stanford classification, I'm going to talk more about that in a second. Was a retrograde dissection? Did the patient have a TAVR within the last 30 days? And did the patient have any other cardiac cath procedure within the last 30 days? Malperfusion, lower extremity dysfunction, extremity sensory deficit, rupture. So these are all questions related to dissection. In dissection, we changed this. Previously in version 2.9, hyperacute was defined as less than 48 hours. They came up with new guidelines that were developed between STS and a few other associations that now defines hyperacute as less than 24 hours. So we keep hyperacute, so we keep the same, collecting the same data. In 2.9, we are going to remain with the less than 48-hour definition as hyperacute. Starting with 4.20 OR dates of July 1st, we're going to define hyperacute as less than 24 hours. Same thing with acute. Acute is 24 hours to less than 2 weeks. In 2.9, we used 48 hours to 2 weeks, so that definition has also changed. These definition changes, they will start with version 4.20 on July 1st OR dates. None of the other timing had changed. Subacute is still 2 weeks to less than 90 days, and chronic is 90 days or more. Dissection, and then dissection onset date known. The definitions are all in the training manual for that. Primary tear location and proximal distal, and then the next question is proximal dissection extent known. So what's a proximal dissection? That means that it's the dissection on the aorta, that it moved closer to the heart. So if you had a dissection in zone 2, the proximal extent would either be zone 1, mid ascending to distal, STJ to mid ascending, or below STJ. So it would be anything above zone 2, which means it's closer to the heart or proximal to the heart. And you'll see here that we stopped here at zone 4. That's because for the thoracic abdominal aortic, we go to zone 5, and so you can't have anything. Zone 6 wouldn't be your primary tear location, because that would not be captured in the thoracic abdominal section, and I'll show you the zones in a second. And then we get down to the distal dissection extent known. Distal is furthest away from the heart, or closest, going down towards your toes. So we would have, again, if you had your primary tear location as zone 2, your distal would have to be zone 2 or below, because you could have a distal tear still within the same zone. And I should have said the same for proximal. You could have a proximal tear in the same zone as the primary. Proximal extent, dissection extent could be in the same zone as the primary. Same thing with distal. You could go then zone 2 to below if that's where your zone 2 was, where your primary tear was at. Stanford classification. In 2.9, we did not collect Stanford classification. We collected it in 2.81 and prior. We have clarification in the training manual regarding what Stanford classification is. It's actually defined by the zones where the proximal and where the distal extent or proximal extent goes, where it leads. So that's how we define type A and type B. It's redundant to capture the tear locations, the distal extent locations, and also the Stanford classifications. But the reason why we're doing it and being redundant is that we want to, it's kind of like a check to make sure that we are capturing these correctly. It also helps analysis of data at your site a little bit more easier, that if your surgeon says I had a type A, how many type A's did I do? You would be able to query this instead of querying multiple zones, multiple other fields for that. The retrograde dissection caused by aortic stent graft, this is post-TVAR. So was there a retrograde dissection after a TVAR? You would capture that as yes. And then I think these are pretty clear. Did the patient have a TAVR within 30 days of the OR date, or did they have any other cath procedure performed? Malperfusion means that you have bad blood flow or lack of blood flow. And if you have lack of blood flow, where did it go? These were all yes or no questions before. They are, which is here, they're all just multi-select. Just pick the ones where you had, the surgeon said that there was a poor perfusion related to the dissection. And then did the patient have lower extremity motor deficit? If it did, the choices, no deficit, weakness, paralysis, and then lower extremity sensory deficit. Was it ruptured? Did the dissection rupture? And then no changes for this section. And then we get into, this is if other. So if I chose up here, my primary indication is either aneurysm, dissection, or other. If I chose other, then I'm going to, choose which one of these others it was. We added an endo leak, infection, injury related to surgical complication, perforation, trauma. We clarified that obstruction is the same as stenosis, valvular dysfunction, intramural hematoma, and coarctation. And then this is additional anatomical information, more information on the root. And then we, in the previous 2.9 version, first, this sinus of Valsalva aneurysm, we only had choose one. And oftentimes you would see some aneurysm or aneurysm-like dilatation in multiple sinuses. So we made this a select all so we could make sure we capture everything here. Got a little confusing when we were telling people to select one over the other, because one of them had more importance than the other, and that didn't really make much sense. So we're just going to collect any type of aneurysm, sinus of Valsalva aneurysm dilatation here. And we have a field here which is arch anomalies, and then this used to be a yes or no field, so we were just going to capture any type of arch anomaly, just check all that apply. Patent internal mammary graft, we had this as a yes or no. Not all patients who are having aorta surgeries have internal mammaries. So we added this NA, which is different than no for these patients. So NA is that the patient didn't have an internal mammary bypass graft. No is the patient had a internal mammary bypass graft, but that was not patent. And then the patient had an internal mammary bypass graft, and it was patent. And then we get into the zones here. Hopefully this is a little bit of a pain point for people. For measurements, largest diameter, previously we wanted all of these measurements for We did both the 3D reconstruction, and then we had this largest, and it was really confusing. Sometimes we would have duplicates, and which is okay, but it's still, that's quite a bit of data fields to fill out, and is it really necessary? And the answer to that question is, we like to have all those numbers, but is it really that worth the burden to collect all of it? So we've went with 3 questions, pretty much 3 questions here. We have, the first is the treated zone with the largest diameter. So what zone was treated that had the largest diameter? The next is, what's the measurement of that zone in millimeters? And the next is, how was that measurement obtained? 3D or 4D reconstruction, a pre-op CT, a pre-op MRI, pre-op echo, or intraoperatively. So that pretty much is straightforward. These are really, these 3 fields are very important to capture on all patients, all aortic surgery patients. But make sure you do your best to get this information. If you don't know, ask your surgeon, because they surely would know prior to doing the surgery what the largest diameter was that they were repairing. The next 2 questions, which is proximal and distal to treated zones. This is very helpful. It's very helpful for all cases. It's even more helpful for endovascular cases, because that's where your landing zones are going to be. So what's a landing zone? When you put a stent in the aorta using endovascular technique, you have to extend that stent to a piece of the damaged aorta. You have to extend it to a piece above the damaged aorta and a piece below the damaged aorta. So it has something to hook on into to healthy aorta tissue. So what we're looking for is the zone proximal to the treated zone, because that then will tell us where the end of that stent went, and then the distal treated zone. So these are going to be the healthy sections above the treated portion of the aorta. Helpful in all cases, very helpful in endovascular cases. If you have it, please collect it. For endovascular cases, I urge you to please work with your surgeons to get this information. It really helps. What's going to happen is, if the patients come back in for a failed endovascular procedure, we'll be able to better analyze those cases and kind of help guide practice related to where the target zones were for stent placement. So these are helpful in guiding patient care and surgical intraoperative treatment of the patient. So you have the proximal zone, and then you can select there the measurement and how that measurement was obtained, and then distal. So proximal closest to the heart, distal closest to the toes. Okay, and then we get intervention, and then this is where it's going to get fun. As fun as the database can be, I think. The intervention section, so this is where you back up at the top in the operative section, you selected that an aortic procedure was performed, and it's any of the yeses. And then we're going to ask that question again. The reason we ask that question again, well, similar question, but it's also going to include the root. So we're asking, was an aortic valve procedure performed or a root procedure? And it could be either of those. So you're like, well, didn't you already ask me if an aortic valve procedure performed? Yes, we asked that, but that was apparent to the aortic valve section. So you can't have this can't have that same parent. So, and we also want to be capturing the root procedures. So I'm going to show you, because previously in 2.9, we captured aortic valve and root procedures in the aortic section, in the aortic valve section. And then if you did a root procedure in the aortic valve section, you then had to go back into the aorta section and fill out a whole bunch of stuff that really wasn't, that really didn't flow very well. So this is what we did here. And this aortic valve or root procedure performed, it can be any of these yeses. And then if it's a yes, what did you do? Well, I did a replacement, I did a repair construction, I did a surgical prosthetic valve intervention, I did an aortic annular enlargement, I replaced a non-coronary sinus, which is a modified Weed or a modified Yakub, or I did a root procedure. And these are all your yeses for this parent, your choices. It mimics the replacement, the repair, and the surgical prosthetic valve intervention section mimic exactly what is inside the, and I believe this aortic annular enlargement, mimic exactly what's inside the aortic valve section. So you would not capture this in the aortic valve section if it was done in conjunction with an aorta procedure. You are only going to capture it here. So you fill out this section. If any of it applies, you would select what applies and answer the corresponding choices. Then we get down into, so I think it's all of these actually. I think it's these that are all in light green are duplicates of what's in the aortic valve section. That's why I had put them in light green to show you that those were duplicate fields. If you're looking to pull out data, when you're looking to see, I want to know how many aortic valve procedures I performed, how many replacements I performed, you would need to pull out data from the aortic valve section for replacements, and you would need to pull out data from the aorta section, that's replacements. So we can go through that in more detail on how to get data out in another webinar. But just so you're aware, if you're looking to pull out data and look at your counts for your site, you have to pull it from two places. A little bit more cumbersome doing it that way, but it's going to should give you a better understanding of, you'd then be able to break it down, which is strict aortic valve replacements versus aortic valve replacements done with another type of aortic procedure. So then we get into the root procedure, and this root procedure is, this was completely moved from the aortic valve section. So we just now have root procedures here in the aorta section, and it's kind of rearranged this a little bit to capture things better after we got some good feedback. We have aorta root procedure performed. Yes, if we did it, was there a coronary osteo reimplantation? Was it a composite graft or valve sparing root? And if it was a composite graft, what kind of, or composite valve conduit, what kind of composite valve conduit was used? We have mechanical bioprosthetic, homograft, autograft, which is with native pulmonary valve, which is Ross procedure. And then if that was a prosthetic, was it stented valve conduit, stentless valve conduit, or stentless biologic full root? Excuse me. And then we get into the valve sparing root, and this is where we capture the David Jacobs and Florida sleeves, which is your valve sparing root with valve sparing root reimplantation, valve sparing root remodeling, and valve sparing root reconstruction, all related to all valve sparing root procedures, and all either reimplantation, remodeling, or reconstruction. And then if we did a coronary reimplantation, was it a button, was it a SVG Cabral, or was it a classic Cabral? These are all new because we got some feedback that sites are doing these, and I think it, it was really difficult to capture these in 2.9, so we added these fields in here. And then the next one is major root reconstruction debridement without coronary osteo reimplantation. And that's all there. And then if that's the only thing you did, and then you don't have to worry about what's below here. You just answer no to these couple parent fields, and then you're done. So we have surgical ascending arch procedure, yes or no. We added in a proximal location. So the ascending and arch procedure, this is the part that comes right off of the valve. I wish I had a good picture to show you. Hold on. So you have your root here, you have on the left-hand side of the screen, you have your valve, and then this is the root section. These little guys coming off the side, these are your coronaries. And then we get into the ascending. So root ascending, within zero we have, root ascending, and then we have the STJ to mid ascending. So STJ is sinotubular junction, and then you go up to the mid ascending, and then mid ascending to distal ascending. Oops, what did I do? And then distal, and then you mid ascending to distal ascending. Those could be your proximal locations. You can't go more proximal if you did anything on the ascending or arch procedure. You can't go more proximal than the STJ mid-ascending that's not already captured up here in this root section. So that's why the most proximal location is the STJ to mid-ascending. And the most distal you could go is zone 3. That's it right here, and that's the completion of your arch. And then we get into the distal technique, distal site, distal extension, and arch branch reimplantation. If there was arch branch reimplantation, then you have your vessels here of what was reimplanted. And then we get into the open surgical descending thoracic aorta or thoracoabdominal procedures. These are going to start after zone, they're going to start, so you have a reverse hemiarch, zone 0, 1, 2. These could be your proximal locations all the way to zone 9. You cannot, you could start in zone 0, and if you do something all the way to 4, that could include your part of your descending aorta, your descending thoracic aorta. And then your thoracoabdominal aorta is this section here. Intercostal reimplantation. So open surgical descending, we had to rename this. I think previously it said open descending thoracic aorta or thoracoabdominal procedure. That gets a little confusing when we start talking about clamping the aorta, and that could be open. You can do that open or you can do it clamped. It's different than what we're asking here. What we want to know, was there an open surgical descending thoracic aorta or thoracoabdominal procedure versus an endovascular procedure or closed type of procedure. So we get into proximal intercostal reimplantation, the distal locations, the visceral vessel intervention, which is your celiac, superior mesenteric, right renal or left renal. And how were these, what was done to manage these? Either reimplantation, which is that they were reimplanted back into the aorta, branch graft, meaning that another piece of material was used to supply blood flow, or there was no intervention done to manage these, that they were either left alone or nothing was done. And I see I have 2 different font sizes. And then we get into endovascular procedure. And we're almost done here, and I'll be able to take a few questions. And if folks want to stay on, you certainly can. If you need to go, it'll be recorded. But I'll see if I can get through some questions. I'll probably stay on until about 3:15 or 3:20 Central Time. If you're able to, please do. Endovascular procedure, we added in here, this is for access. So carotid had become a little bit more popular, so we added an option in for access for carotid. And then I think we did some spelling fixes or something. So left subclavian axilla, right subclavian axilla. This is your endovascular procedure. Where did they, where was their access? Was it percutaneous? And what were your landing zones? These are all described. Again, landing zones are usually the zone above the treated zone. So you just want to make sure you read the definitions in the training manual, make sure you're collecting it right. My guess is that your surgeons will be consistent in their documentation with each patient. So once you reach out to them and get an understanding of how they document this information, it's probably going to be consistent for the rest of all of their other operative reports, but it's always good to check with them if you're not sure. And then this is arch vessel management, inanimate, left carotid, left subclavian. How were these managed? And then visceral vessel management. And actually, I think that we should have, I might have to add in a column here, because I think that these are all children of endovascular procedure performed. So I'll have to check that out and make sure. If it is, I'll just update the data collection form to add that in. And then we get down visceral vessel. The choices here, native flow, that there was really no vessel management done. Endovascular branch graft, so they put a branch graft in endovascularly, a parallel graft, extra anatomic bypass, which is sometimes I think that those are done open, which makes it a little bit more confusing when we're talking about endovascular cases. but I think we have pretty good clarity in the training manual on that. And then fenestrated, and then no flow restored, which means sometimes they, for whatever reason, it's very uncommon, but sometimes in the innominate artery, they do not restore flow. And that would be that graft or this vessel would not have any flow in it. So we added the no flow restored selection. And then if extra anatomic bypass, where did that go? Where was that bypass located between? And then these are all, I think, straight left renal. You have your choices here about how that was managed. If it was extra anatomic, was it aorta, left renal, iliac, left renal, or other? There's different choices under, so like the iliacs will have femoral, or other. The other visceral, was it aorta, other, iliac to other, or just other? And then we have other endovascular procedure information. None of this really had changed from 2.9. The only thing, we just added some clarity about this is unintentional rupture of a dissection septum. And if yes, where was that rupture located? And then additional procedural information. No major changes here. We did add in this last choice. This is something that came up about endovascular balloon fenestration of the dissection flap, and when was that done? Excuse me. This is something that your surgeons will clearly chart if they ever do this. It's a balloon fenestration. There might be a flap of the dissection that they fenestrate with balloon. So it's clarified in the training manual what that means, but your surgeons will, very likely that your surgeons will be clear in their documentation if this ever happens to the dissection flap, and it can occur preoperative, intraop, or postop, which means you may find this information in the consultation, the operative note, or in the postoperative notes from your surgeon or surgeon's team. For the device section, we have devices. We have aortic valve or aortic valve composite graft implanted. If yes, this is the valve or valve composite, which means that you did a valve by itself, or you have a valve, something that might go up a little bit further and provide some flow to the root. This is where you would capture those. And then if you go down a little bit further, this is where we're going to capture aortic valve or aortic valve graft composites. Did I do that twice? Yep. I think we just have to clarify these. I'm not sure if we're going to collect these twice. Let me check with Melinda and see if we had a different intention for what this is, or if we need to remove this wording and just collect valves here. ABC are these three that fall into zone 0, and then zone 1 is letter D through zone 11, which is N. And then refer to the data specifications for the harvest codes. I don't go off of what the zones say. This data specifications will have more clarification on that, and let me show you real quick. Sometimes it's easy when you're abstracting if you know the harvest codes that you're using. So you would get used to, hold on one second, 5450. You would get used to quickly entering the data in if you knew the harvest codes. The caution with that is that harvest codes can change with, harvest codes can change between versions. So when we start the new version, it's important that you don't assume that you know the harvest codes, to make sure that you, first couple cases that you do, just to get this back in your mind, that you're coding using the correct code. So like below sinotubular junction, you may assume that, oh, that's the first choice here, so I'm going to choose 1, but actually it's the second. It's harvest code 2, and then all the way through zone 11 is harvest code 15. So just check these if you're a quick data abstractor and you like to use codes when you're entering. Make sure you verify because they do change between the versions. And then that gets us down to the end of the aorta section. And then the next time we talk, we'll just talk briefly about the congenital section and then go on into the postoperative section. We do have some changes. This is postoperative section. We do have some changes here. We removed quite a bit of information, I believe. We'll go through that. Not quite a bit. We moved some information, but when we get into the postoperative event section, we had some significant changes that we'll talk more about during that time, during our next call when we talk. So let me go to the Q&A and see, we have quite a few questions in here, and I'll see what I can answer. And I'm not sure who's on with me. I'm not sure if Melinda's on or not with me.
I'm here, Carol. I was on the wrong link listening for a while, and then I figured out the right link, so I'm here.
Good. Thanks for joining. Did you have anything to add to the aorta section, or want to just go through these questions?
Maybe just go through the questions. Yeah.
Okay. I'm going to, so let's see. Melanie, are you still there?
I'm here. I'm answering those. You can just go to, you have a lot of aorta questions. So
Okay.
I'm still answering.
Okay, great. So we'll start here. I think that okay. I think I'm going to start here. Where would you put a surgery that congenital issue done on an adult? So that one we're going to cover next. We're going to cover that next call where we start in the congenital. We'll start with the congenital section, but if you participate in congenital database, you can enter it into the congenital database. If you do not, then you can enter it into the adult cardiac database. Next question. I'm confused on that aorta section, yes or no, in the second section. So I'm not sure, Beth, if you want to reach out to me with, after we've gone through it now, if you want to reach out to me and let me know what your question is, I'll be happy to answer it. And I'll ask if Leanne is listening, if she could put my, dare I say, put my email in the chat box, and or put the STS FAQ email. I think that would probably be better so Melinda can keep track of these questions. We could provide clarity in the training manual. If Leanne, if you're available to put the STS FAQ link to submit a clinical question or direct email into the FAQ mailbox. So is an aortic root replacement alone need to be in both sections? So I just went through that. The aortic root only goes into the aorta section. I think a lot of these questions came in as we were going through it, and it's really important to listen to the whole thing, because most likely your questions are going to be answered as we're going through it, and then as we get through it, if your question's not answered, then please ask. What if the patient just has an aortic procedure performed? Can you review what gets answered yes and no? So if it's just an aortic procedure and no valve, then you would answer the questions that are asked that say, was an aortic procedure performed? Yes. And then when you get down to the valve section, you would just answer no. You wouldn't even get to that question about I'll show you. So you would get here, you would say an aortic, where'd it go? There they are. You would just say, was an aortic procedure performed? Yes. Was a valve procedure performed? No. You wouldn't even get down to these questions if a valve procedure was not performed. A root procedure is an aorta procedure. So if you do a root procedure, you're going to capture it under the aorta section. If only an aortic procedure is performed, that question under aortic valve procedure performed does not need to be answered. Correct. Correct. You just answer the aortic procedure performed yes. If no valve procedure was performed, you select no. Can you speak about completed worksheets by the surgeon? At my facility, he reviews and initials them for assisting in abstracting and information obtained by the worksheet, but not documented, for instance in the op note. So I would work, I guess if your surgeon is signing them, you could take that as documentation. You would really need to double check with your facility to make sure that that's okay if it's signed, if it's scanned into the chart, to make sure that that's acceptable for documentation. I also make sure that you don't have inconsistent documentation or conflicting documentation on the worksheet and what's in the operative note or any other place. If you do, you need to work with your surgeon or surgeon staff to correct the conflicting information so you have correct information to extract. What's the difference in the valve section? The two questions that are essentially both asking, was a procedure done on the aorta? So again, one section, if you have an aortic procedure performed, yes, this is going to open M2. If a valve procedure was performed in conjunction with the aortic procedure, you're going to select yes here. If that valve procedure, of course, was the aortic valve procedure, you would select yes here. This question, was a procedure performed on the aorta, is actually the parent to the aortic valve section. You have to answer no here to get to the aortic valve section. If you, so that this is what's blocking M2 from opening. If there's an inconsistency, it's going to fire in your vendor software. How will this delay in getting 2019 year-end harvest affect the star rating? So your star ratings will still be posted, will become available with this report that's coming out in the summertime. If patient had an aortic procedure with no valve involvement, do we say yes to AVR in order to be answered yes to aortic procedure? No. You just answer yes to aortic procedure performed. If there was no valve procedure performed, you answer no. Version 4.2 upgrade on delirium as a post-op complication and metabolic must be diagnosed. Okay, can you clarify? So Heidi, if you could just send in, we're not quite there yet in this review, so if you could please send in your question to the FAQ mailbox, Melinda will be happy to answer that for you. When will you be providing benchmark data for the aorta procedure similar to what you do for cabs and valves? So we have enough data now that our quality metrics task force is looking at building a multi-procedural composite for aorta procedures. Those usually take a couple years to build just because of all the back and forth with what variables go in and looking at the impact on each variable, risk, procedural variables that go into building risk models and assessing risk properly. So it can take a year or so to build those models. They are working on that now. So we should have aorta models out. I just don't know the dates. The surgeon worksheets will be available probably within the next week or so. In 2.9, how do we code endo leak of previous procedure since other is not an option? In 2.9, how do we code endo leak of previous procedure? So in 2.9, we capture endo leak. You can capture it in this section here, in the aorta section. If it's an aorta procedure and the patient had an endo leak, you would capture it here. I don't know that we capture it for other procedures. So you would, 2.9 is the left. This language is not correct. What was in 2.9, it just said was, here it is, endo leak, yes or no. So even if it was related to this procedure or if this procedure was being done for an endo leak or not, and the patient just happened to have a history of endo leak, this is where that is captured here. So I'm not sure if I'm following your question. If not, feel free to email it into the FAQ mailbox. If a patient has a 3-vessel CABG and one is closed while the other 2 are patent, how to fill that? I'm not sure what that, Melinda, do you know what that question means?
I'm wondering if he's asking about the grid, but that's all I can think of. I'm not sure. I assume it's the grid, but you know what they say when you assume. So, hey, Rob, why don't you send that question in to me?
Thanks. If a patient has a root aneurysm, are we supposed to pick sinus of Valsalva aneurysm and choose right, left, non-coronary? And so a root aneurysm is not the same as a sinus of Valsalva aneurysm. Is that correct, Melinda? Root aneurysms, they may not impact the sinus of Valsalva aneurysms. I had a nice picture.
Yeah, I mean, they often are, but
yeah.
Let's say.
Let me see if I can find the picture. Oh, it's because I have it here. See if that pulls it up. So if you could see my screen, this is the valve. These are the cords connecting up here. These are the coronary sinuses, right? So you have, there's your coronary artery. This is the non-coronary sinus. So your aneurysm would be within this section. So it's different than, I believe it's different than any place on the route, but we can clarify that in the training manual after we get some guidance from the surgeons to make sure I understand the question correctly. Method obtained could be many, select only one. I'm not sure what your question is. Oh, are you asking about the measurements? I'm not real sure what you're asking, Debbie, on that. So you may want to, if you could clarify in the mailbox, in the Q&A section, I'll be happy to answer that for you.
Yeah, there is a priority in the training manual, I think, if you've got different measurements.
Yeah, and I think we put these lists, if we're talking about the measurement section, that's what I would agree with you, Melinda, and we put these in order of priority on the form here. So if you have more than one, we would go with the 3D or 4D over a regular CT or over the CT over the echo. So this is the order that we would go with. I'm not sure. I think that's what we have in the training manual in that order. Okay. Are endovascular procedures now required or optional, similar to TAVR or TMVRs, where they can be entered but are not analyzed? So the endovascular procedures we're talking about here in this section are related to the aorta, procedures of the aorta. And those are required if they're in the thoracoabdominal or above area. If any part of that endovascular stent goes into the area above the diaphragm or above the renal arteries, then that needs to be entered into the database. TAVR cases and TMVR cases are different than these types of endovascular procedures. These procedures are transcatheter valve procedures, and they get entered into the TVT registry. They are not required for the adult cardiac STS ACSD registry. However, you can enter them. They will still not be analyzed, but some sites will enter into TVT and ACSD for these TAVR and TMVR procedures.
Yeah, and I would just add, Carol, that T-bars are required, E-bars are not entered.
Right, thank you. Will a section for recording zone measurements be added to the aortic procedure surgeon's worksheets? I've never once had these documented, but I think we would be more likely to get it if it was part of the worksheet for the surgeons filling out. So
I did put it on the worksheet this time, the one that I sent over to you that you're reviewing now.
Mm-hmm.
It wasn't on the older one, I don't believe.
So I thought it was, okay, so yeah, we'll make sure that it's on there so you can capture that. I think I remember debating with myself about how best to do it because it was such a lot of information. So now it's kind of slimmed down, so we'll be able to do that. You can also, the worksheets are posted in Word format, so you can always add or manipulate those forms however best works for you and your surgeons. Again, Heidi, I see your question. Please enter in your to the FAQ mailbox so we can answer it there. To clarify, aortoplasties are not captured, correct? So if the only procedure you're doing is an aortoplasty, that's not captured. But if you're doing an aortic valve and you're doing an annulus enlargement, then that is captured. Anything to add to that, Melinda? I'm not sure. I'm not sure where we got. I mean, I don't know where we got off. We got on the idea that aortoplasties are something that's done.
Right. Generally, we don't capture aortoplasties. And if you do it with an AVR, it's not even considered a procedure. So I think people get confused because in the history, it asks about a history of an aortoplasty. So I think that's where they get confused and they think they have to enter it in, but we really aren't capturing aortoplasties.
And if we're talking about an aortic, an annulus enlargement that's done with an AVR, it's common, very common for an annuloplasty or an aortic, an annular enlargement to be done before they seat the valve to make sure there's enough room for that valve to be placed, and so that you have a big enough annulus, so you don't have a small annulus which will restrict blood flow. So it's a very common procedure to do with valve procedures to enlarge that annulus, and it does not impact the way that procedures are captured. So you wouldn't capture that aortic annular, the annulus enlargement. That's different than this aortic annular enlargement, correct, Melinda?
Yeah, I mean, a lot of times they'll do that, and then they may often do an aortoplasty too, which we don't capture. Don't capture it. It's not considered another procedure. The surgeons feel like it's just part of the procedure.
Great, thank you. Do you have a sample case to try abstracting with reasoning of why it was abstracted per the STS training manual?
We don't, but that's actually a great idea. We don't have anything like that.
No, but that may be something we can do after we get through the upgrade and get everything posted. We might be able to provide that for you. I think that's kind of a cool idea, actually. Will an aortic annular enlargement drop the patient from risk model if all they had was an AVR and aortic annular or an annular enlargement, or if annular enlargement is also in the valve section, if all they get? No, it will not drop the patient from the risk model. I want to confirm the aortic valve section is just for isolated AV repair replacement. If we have AV plus aortic aneurysm or root procedure, this would be captured under the aortic procedure section only. That's correct. The aortic valve section, like we went through it with when we went through the valve section, we talked about that. We talked about the only things that go into the aortic valve section are replacements, repairs, or surgical prosthetic valve intervention. These are the only things that would go into this. Again, these are all part of the valve procedures, the aortic annular enlargement and the modified Weger, modified Yacoub. These go here, but if it's anything other than this that's involving the root or then it's going to go into the aorta section. What is the difference between root remodeling and root reconstruction? So they're rebuilding the root or they're remodeling the root. I'm not sure. I guess, do we provide more clarity in the training manual between the differences of those two procedures, Melinda? Or is that something we should?
Are they, can we look at the field I think they're talking about?
Yeah, it's this one here, valve sparing.
Yeah, in the training manual, there's a description of the nicks and oh, never mind. Yeah.
No, it's the David Yacoub and the Florida State. And
I'll tell you, I think I've got some pictures of what I could find in there.
It's more than one or two sentence definition of what the differences is. I suggest Googling what a David, what a Yacoub, and what a Florida sleeve procedure are and learning about them that way, or looking up, talking with your surgeon. They're pretty technical when we get into the definition of what the differences is between those. But they would be documented as either remodeling or reconstruction or Yacoub or Florida sleeve. You have chronic dissection as etiology for the aneurysm. If the patient has a dissection and we list that correctly as the primary reason for surgery, it closes the section for aneurysm. Are both sections going to open now? So if the reason for surgery is that you have a dissection, then you're going to select dissection and you're going to fill out the dissection section. If the primary reason for the procedure is aneurysm and the reason for the aneurysm is chronic, where did you say that?
Right there, chronic dissection under etiology at the top there.
Why aren't I seeing it? Oh, here. If the patient's going to the operating room for an aneurysm repair and that aneurysm is related to a chronic dissection, that's where you would capture this. And then you say if the patient has a dissection and we list that correctly as the primary reason for surgery, it closes, yes, so it would close that. So if you're saying the patient's going to surgery for a dissection, the reason for the dissection is chronic dissection, we don't capture that here, right? It's just a dissection. And no longer is that dissection chronic, that dissection is now acute. Do we have to open the aorta section to do an AVR procedure? No, only the aorta section. If you only did an AVR procedure, you just answered that you just opened the aortic valve section. When pulling data on valve procedures, you stated 2 different elements are needed to be pulled. Could you repeat that or explain, please? So if you're pulling information on aortic valve procedures and you want to see all of your aortic valve procedures performed, you have the first place where you're going to pull it is up in the operative section. Get up there for you. Up in the operative section, you have AV procedures. So this one, aortic valve procedure performed, VSAV, yes. And actually that's pretty granular. You can just pull it from there. And that's, I think that actually you probably just need to pull it from the one place. If you wanted to look at aortic valve procedures performed in addition to any other aortic valve procedures and you want to break those out, you would pull it from, I guess you would pull it from the aortic valve procedure performed, yes. And then in the aortic valve root section, you would pull that. But actually this 2131 will give you all of your counts for aortic valve procedure. So I think I misspoke when I had said that. I think I was overthinking it. Does that make sense, Melinda? All aortic valve procedures, if you want to get a count for any aortic valve procedure, you can just pull it from here with or without an aorta procedure attached to it.
Would think so.
Yeah. If you wanted to get more granular and you want to look at things like Bentals versus straight AVRs, you have to pull out the Bentals and then you would have to pull out aortic valve procedure performed, yes. And then you would need to probably pull out the nose from that. This aorta procedure performed, I'm sorry, the aorta procedure performed, yes, from the 2131 to get your counts. It would be really great if we had a complete session on the aorta, full review and surgery with specific examples. So send in your example and I'll be happy to do a case abstraction live for you to show you how to abstract that case. Are we supposed to collect all TVAR cases or is it optional? TVAR cases are required in the database.
If the CT surgeon is participating, and usually they are because it's a TVAR.
Yeah. Can you explain the aortic valve parent-child again? Okay. And I appreciate all the questions because it took a lot for us to figure out how to do this without having to double capture things. So if you do a procedure on the aorta, you would select any of these yeses. If there's no procedure on the A valve, you just select no, and the aorta section is going to open. You can collect your aorta information in there. If you do a procedure on the aorta and that procedure involves the aortic valve as well, you select yes to the aorta procedure, you select yes to the valve procedure performed, and then you would select yes to the aortic valve procedure, and then you would select no, then you would select yes to the aorta procedure again. This check here where it says procedure performed on the aorta, yes, and any of these for 2123, yes, that's a check. So there has to be consistency between these and this field here. Now, if you did not do an aorta, you select no, okay, fine. You did a valve procedure, yes. You did a aortic valve procedure, yes. And then, are you sure you didn't do a procedure on the aorta? No, I did not do a procedure on the aorta. This no right here is what's going to open the aortic valve section. You can only have one parent to a child. It gets a little confusing when we talk about how it works in the programming world, but in order to open up just the aortic valve section and not open up and to make sure that we're not double capturing aortic valve information, this question was a procedure performed on the aorta, no is going to open up the aortic valve section. So again, procedures performed on the aorta, yes. Valve procedure, no. Aorta section will open. Aorta procedure performed, yes. Valve procedure performed, yes. Aortic valve procedure performed, yes. Procedure on the aortic valve, yes. Aorta section will open. Valve section will not open. Aorta procedure performed, no. Valve procedure performed, yes. Yes, for aortic valve, procedure performed on the aorta, no. Valve section will open. So maybe I'll write it out next time. After we get through the rest of the sections, I'll write out a PowerPoint slide next time, or when we get to talking more about it, and I'll show pretty clear how you get to each section. I think that might be a little bit helpful to have it written out a different way too, instead of looking at all this. Let's see. If you make any further changes to the form, can it be noted in a Word document with the sequence number noted? I guess we could do that. We'll see. For the implants, I thought I heard you only want the first device most proximal entered. If so, why is this data entered in the table? No. So it's not the most proximal device entered. You enter all. Huh?
We are the proximal side and the distal side for the devices. For the aorta devices.
We enter all the devices entered into the patient. If you
Exactly. But for
valve, and then you enter a composite, you enter something into the root, and then you enter something into the ascending, all three of those devices would get entered.
Right, you enter all the devices.
Yeah, all the devices get entered. If the surgeon creates a valved conduit using a bioprosthetic valve and a graft conduit sewn together, we marked valve conduit, correct? I say yes. I say it would be a valve conduit, but I would say submit that into the FAQ mailbox so we can run it by the aorta surgeons to make sure we're collecting it correctly. If there's an aortic valve plus an aorta replacement that is not a valve conduit, how are those devices captured? So you would capture the aortic valve separately, and then you would capture the part that's placed into the aorta separately, so two devices. Right, so you would enter, I'll show you. I don't know, is anybody still on the phone call with us? You would enter the aortic valve here, and then you would enter the graft material here.
There's still 217 people on the call.
Okay, as long as people are still listening. We are currently using a third-party vendor for our data warehousing, reporting, and submission. If we choose to do the direct data entry through IQVIA, would there be extra fees? There's no extra fees to do direct data entry through IQVIA. Also, our third-party vendor allows us to customize our reports for quality assurance and specifications made by our CT surgery medical director. Will IQVIA platform allow us to do this? No, there is no reporting like that your vendors allow, that IQVIA is going to allow. It's regarding the question in the aorta section that asked if the patient had previous cabbage surgery. The new version added NA as a choice.
Oh, that's what he was asking about. So he had 2 grafts down and 1 patent. That's asking about a patent IMA.
Yeah, so this is the internal mammary artery. So if they do a lima or a rima, they're asking if that graft, if that internal mammary artery, or if they did bilateral internal mammary arteries, if they're patent. I think it's a good question, and I think what we're looking for is probably the one that goes to the LAD. If they did a bilateral internal mammary artery graft in a procedure, that's a good question to clarify with the surgeons if we have 2 internal mammaries and one is down, one is not.
Right.
So I think
That's a good question.
We can clarify that. On the harvest report that came out Monday, if you have errors to correct, how will correcting the errors affect the star rating coming out this summer? It will not. So your data that has already been submitted through the data that contained OR cases through December 31st of 2019 is already in analysis. So your star ratings are being calculated right now as we speak in the big machines at Duke. And then they're going to send it back to IQVIA, and then we'll have our benchmarked or analyzed dashboard available to post for sites to see their analyzed data and their star ratings with data through December 31st, 2019. The data that's now in this harvest summary report, which is kind of like an all-inclusive harvest report that shows you everything that's you've harvested. That's why we call it a harvest report. It shows you everything that you've harvested for a specific time frame. You can look at time frames all the way up until the last time you made a submission into the IQVIA portal. You can look at your errors and warnings. That would be reflective if you then went into your vendor software, made a correction, and then resubmitted that data. The harvest summary report will be updated with those corrections, and you'll be able to see near real time reflection of your corrections that you submitted, and they will be, depending on the time frame, if it's data that's being used for the harvest 3 report, which is the one that closes in August 23rd, I think it is. That's your star rating, the second star rating for the 2020 year. Then it will be reflected in that report. The report that's coming out this summer is already in analysis, so there's no way to change that data or change that star report or data that's in analysis. If a vascular surgeon does an aorta procedure, it is not an STS member. It does not go into the database. Right, that's true. Your surgeon has to be an STS, not STS member, but has to be on your participant contact form as participating for your site.
But if a CT surgeon is doing it with him and is on the participant agreement, then it goes in.
That's right. Yeah. So for TVARs and EVARs, is it the same answer for version 2.9? Enter TVARs but not EVARs. That's correct. So no TVARs, but your EVAR. I'm sorry. You enter the TVARs but no EVARs. I almost did it again. I had to put this slide up. So that's that. Yes, your TVARs go in. Your EVARs do not go in. So to clarify, we should enter all TVAR cases into the adult cardiac surgery. TMVR, TAVR do not have to enter as they are not analyzed. Correct.
Correct, but the TVARs have to have a CT surgeon on a participant agreement. If there are vascular surgeons out there doing TVARs by themselves and they're not on your agreement, don't put them in.
Next question. It seems like changes are still being made. When will the vendors receive these changes? Do you think we will have the database ready for 7/1/20? Michelle, could you please clarify what changes are still being made that are going to impact the vendors? Because what I talked about today, I don't know that I think it was just formatting changes on the data collection form, which do not impact the vendors. Go live is 7/1/2020. If aorta prac yes and aorta prac yes, then yes and yes. Why won't the aortic valve section open? The aortic valve section will not open because you're going to capture the valve within the aorta section. I read through the questions and answers to see when the surgeon's worksheets for 420 would be available. Saw that question answered live. I missed it. On the STS site, it says surgeon's worksheets coming soon. Correct. They'll be out soon. Are we still capturing COVID results in new version? Yeah, we're still going to capture those using the temporary fields. I'm just waiting for the vendors to complete the certification. We have, I think, 12 vendors going through certification for adult cardiac. 4 of them have completed and have passed the first part of certification, and I believe some vendors are sending out their new version software to the sites now. And they're updated on the websites, those that have met criteria to pass phase 1 certification. The phase 2 certification is the risk model certification, and this vendor's getting their software out to you is not dependent on that passing of certification. It's to calculate the risk scores, and that should be completed pretty soon. We're just finishing up some discussions with surgeon leaders at other some centers to make sure we're capturing cases a certain specific group correctly. So I'm not anticipating changes there, but those risk model risk models will be out to the vendors soon, hopefully within the next week or two. And that does not impact go live. And then COVID fields, we're still going to utilize the temporary fields. So once we get more vendors certified, and I'm comfortable that we haven't gotten any negative feedback from the vendors, no parent-child issues that they're identifying, no data collection issues that they notice, then I'll add in those temporary fields back into the same section where they're at in 2.9. Those do not impact anything because they're temporary fields that are already built into the data specs. So we will still be collecting that in 4.2, and I'll add those fields in. I'll probably add them in very close to go live and update the data collection form just one more time once we get any other feedback. I don't want to keep on posting forms and confusing people. So it's better to just do one form with changes highlighted. If you do a valve sparing root operation, what do you pick for 4952? Repair or leave it blank? Okay, 4952. Let's see. Procedure performed. So what are we doing here? We're doing a valve sparing root procedure, which is down here in the root procedure. So nope, we didn't do a replacement. No, we didn't do a repair. If you did a repair, then you collect it here. You leave that blank. So you're going to capture yes here to aortic valve or root procedure performed, yes. You're going to leave the replacement. You're not going to check any of these. You could, figure out if you did an annular enlargement. Then you get down to root procedure. You're going to select yes. And then the root procedure is where you would capture your valve sparing root procedure, David Jack Huber, Florida sleeve.
I'll add one thing to that, and this is in the training manual. If you're doing this and you also do a leaflet commissural resuspension suture, then you're going to put that under the repair.
Right, correct. Where did it go? I know we had that suture in here.
Right there, it's number 3 choice over here.
Right, leaflet commissural resuspension suture. So that is something that's commonly done with the valve sparing root procedures. You just have to make sure in your surgeon's dictations, if they dictated that they put a leaflet commissural resuspension suture in, you have to check repair here and answer this question. So you collect that repair type. And then you can go down into the root section and capture your valve sparing root procedure. Is it the facility's choice to put a local CT surgeon on the STS list? Yes, it's up to the facility. If they want to put their locum surgeons on the STS list, they have to fill out the participant contact form in a Schedule A to enter those cases. So if you do not want your locum surgeon on your list, then you do not enter the cases that locum surgeon performed. If they do that, if the locum surgeon is working with a surgeon that's on your STS participant contact list already, then you can still put that case in. It has to go underneath the surgeon that is listed on your agreement. If a CV surgeon is listed as assisting MD and an interventional cardiologist is listed as the primary, for a TVAR, does that case get entered into the adult cardiac? Yes, as long as that surgeon is listed as on your agreement with STS. I don't see the COVID question, right? So the COVID question will be added as we get a little bit closer. I just want to wait for feedback for some more vendors. 4 are certified, 8 more are going through. As soon as I get feedback that we're all clear, I'm going to add the COVID fields and then repost. For the valve sparing question, there is no yes or no for replacement or repair. So will the vendor make this a drop down? So actually the question here is procedure performed is the question. The choices for procedure performed are replacement, where'd it go? Procedure performed, and the choices for procedure performed are replacement, repair, and surgical prosthetic aortic valve intervention. So those are the choices for procedure performed, and then the root procedure is down here as a yes or no. So when you get down to valve sparing, the valve sparing question, you just leave these blank. The valve, this one, and this one you leave blank, and you get down to root procedure and you code that as a yes. And then you can code your valve sparing root procedure. Is the hyperacute timing from time of start of symptom or to OR entry? So it's the hyperacute is symptoms that occurred within the 24 hours up to OR entry.
Actually, in the training manual, it says the intent is to define the time interval from occurrence of the dissection until presentation of the patient. So maybe, if I don't know if we need to clarify that further or not.
Let's see, hold on.
Sequence 4745.
Okay, let me scroll real fast and
4745.
the occurrence of dissection until presentation of the patient. And we define occurrence of dissection from symptom onset.
Mm-hmm.
So it would be the time the symptoms, so I guess it's, are you saying it's if the patient had symptoms right now and they went to the hospital, that would be hyperacute. But if the patient had symptoms now, went to the hospital in more than 24 hours from now, that would be acute.
Right.
Okay. We could put.
That's how I'm reading it. Now, if we need to clarify it, but
Yeah.
this is the same as version 2.9.
Yeah, let's clarify it, or at least maybe we could put some examples in to make it a little clearer for people. Uh-oh. There was an AV resuspension question in 2.9. How do we code leaflet resuspension? So I think Melinda just answered that question. It's under the repair section, the leaflet commusural resuspension suture.
Yeah, that's where it's at now.
Okay, I guess that's it. We did good. I think Melanie's still on. She may have had to hang up, but I know somebody was answering questions, also answering questions and typing them in. So thank you so much. It looks like we're done now, and I appreciate everybody joining and staying on late. Thank you, Melinda. I know it was a long call. Appreciate it.
You're welcome. Thank you I'm sure your voice is about hoarse by
I
now.
need some water. I need some water or something. It's getting dry. Thank you, everybody, so much, and have a great day. Rest of the day. Our next webinar. Hold on, don't go anywhere. I'll tell you. Our next webinar is coming up here. See if I can pull up my slides real quick. Maybe.
It's next Thursday, I believe, right?
Yep, 25th at 2 p.m. Central Time. And then our monthly webinar is July 1st at 2 p.m. Central Time. We'll probably focus both of these webinars on the upgrade just in case we if we don't get through it. I just want to make sure we get everybody the information before or very near to go live. So that's where we're at with that. And look for the surgeon worksheets in the upcoming week. I'm just working on some formatting changes. So thanks again for joining. I hope you have a great rest of the day. Stay safe, and I look forward to talking to you all again. Thanks, Melinda. Thanks, IQVIA team, and thanks, my STS family. Take care. I'll talk to you guys later.
Bye.
Bye. Thanks.